Okay, welcome to Frugal Science. I'm excited. Several of you are still here. This, I'm assuming, is week 2 or week 3 now. I don't even remember. I'm calling in from Senegal. I'll talk a little bit about Senegal today, but I am in Dakar at Institute Pasteur. It's a remarkable place. And the reason I'm here is we are teaching West Africa Malaria Control and Elimination Program course with 20 students from countries across West Africa and several of us from different universities and campuses. So I should be back by next week, but this has been, I'm teaching in the day and then I'm also teaching at night. It's so it's nonstop. But I think it's sometimes I will talk about malaria today, so it's relevant to be here and think about places and put yourself in a context of the problem that you care about. I see some people, I'm assuming everybody that's connecting has had the chance to do an introduction to the class already, right? Is there anybody that's completely new that has joined more recently and hasn't had the chance to introduce themselves? I don't see any hands, so I'm just going to assume you guys have at least listened in. I'm assuming most of you have seen the optics lectures per se. I think every week we'll try to do something more technical and something more problem-oriented. So I think you will see us switching back and forth. Keep track of these sets of threads, and eventually they'll start connecting. So just before we start, we were starting the discussion on by the numbers. I'm looking for a few volunteers who might want to discuss their assignment. What did you find out? What was a problem that you chose? And where did you get stuck? The harder the problem, the more interesting the discussion will be. So we'll just do this for first 10 minutes or something before we switch talking about malaria. But anybody wants to just jump in?
Yeah.
In the class, online, Yuki, go ahead. And then folks that are listening, if you can all, for discussion especially, if you can turn your cameras on, it's much more fun for the person speaking. It's impossible for us to be in the same room, but there is a sense of feedback associated with people being here. Even when you don't say a word, I can sense confusion, I can sense excitement. So it's very useful for both us and everybody to kind of build a much more of a stronger connection with everyone. So unless you have circumstances that you can't turn the camera on, it's very useful to see people. Okay, Yuki, floor is yours. I want to know, what is the problem? Where did you get stuck? Try to summarize it because I'm going to try to go through 2, 3 of them quickly.
Sounds good.
Salient points.
So the problem is the cassava root problem, which we're trying to figure out the best way in the local resources that we can get rid of toxins so that people can consume cassava roots.
Can you repeat the problem explicitly for people that didn't hear it the first time?
Sure. So the problem is so for certain regions that have a lack of water resources, such as in Congo or some South Indian provinces, people cannot process their cassava roots properly. Therefore, by consuming a lot of toxin in the cassava roots, they develop these neuropathological diseases. So we identify areas in which that we can sort of alleviate the problems, either by helping them process the cassava roots properly through some chemical process, or trying to identify water that they can reuse for filtration and clean out of toxin. So that's the general problem. And also there is a microbiome solution in terms of trying to help people to process the microbiome better. The question that the problem that I'm stuck at is finding my right of expertise to solve this problem, because I think I know people who are working on the gut microbiome side, and I know the samples is on a different country or a different continent, and I know that they're the institute that have the right processing and right technique that's also in a different country. And the road that I'm seeing is that I'm connecting all these people and their problems, but there's not personally I can do. So that's sort of
I think maybe this is I want you to take a step back. So by the numbers, even before you start thinking about solutions, you want to understand the scale of the problem. So what does that scale look like? What is the percentage of population that eats cassava, for example? Then what is the percentage of population in these regions that eats cassava that's unprocessed or not processed properly? What is the actual quantity of toxin or concentration of toxin a person is consuming per day? What is the probability that they actually develop a neuropathological phenotype? What is the age at an average point where it strikes the most? What is the total duration of symptoms? What does the demographics and financial capacity of a person look like? So this is removing yourself. The goal here is to remove yourself from the solution phase, because we often think about solutions just driven by our capabilities, our interest, our technical knowledge. And the goal of this exercise is to remove yourself from the solution hat, but just first truly deeply understand the problem. And sometimes in those numbers lie a different approach. And so, I think it'll give you kind of a sense that if this number ends up being very large, suddenly you realize that, oh, wait a second, this is not a niche disease. Uh, the World Food Organization should actually be interested in this. And so suddenly your approach might change completely, that there is a top-down support for something. So do you know, kind of, for example, annual deaths or annual number of patients that develop symptoms? Is there any reported cases? Because remember in Congo, I was reading the news and it was 40, 50 people, right, that had severe disease pathologies. Or am I off by orders of magnitude?
I think severe, I think there are four level of category of causal disease, but then when you get to the last one, I feel like maybe we should include people who are at earlier level as well. The only
Absolutely. That's the goal of the by the numbers. But I'm curious, were you able to dig in and are there some numbers available?
Yeah, at least according to Wikipedia, in
Yeah.
2000, I think 10, Consul has 11 110,000 cases of Consul.
Mm-hmm. So 110 just in Congo alone.
Yep. Okay.
110,000.
Mm.
Okay, that's a very large number. And so suddenly, I was thinking only about the severe consequence of the disease. That suddenly is a massive population. Do you know what the population of Congo is? Just
Nope.
so, that's kind of the purpose of the exercise, is to write this all down and present it in a manner that you are able to convince somebody that this is an important problem. And then there might also lie some solutions in that. So I'll see, anybody else wants to go and present what they did in terms of, and again, I'm not talking about the solution space. It also doesn't have to be a problem that you are going to work on as a project. It can just be an exercise. So any volunteers, either in the classroom, on campus, or anybody online, you can all just raise hands. Remember, nobody's judging you here. So by discussing, you get feedback from everybody. Otherwise, what's the point of all this? Uh, it'll just sit somewhere in a piece of paper.
Yeah, we
Uh,
have
so
someone in the
I'll wait a few
class.
seconds.
Manu.
Okay, go ahead. So Hope, I'll let you take the one person in the class, and then I see Suraj hand. After that, the second person, I'll take Suraj.
Hello, can you hear
Yeah,
me?
I got it right now. Either after the class or tomorrow. Yeah, sorry guys. It's I have the students here coming by now.
Can you hear me okay? Okay,
Yes.
maybe you can't see me.
We
My
don't
name
see
is,
you, so maybe you can just say your name. Yeah.
yeah, my name is Janella, and I think in the class in general, a lot of people talk about problem of lack of access to healthcare because of different reasons. And I think something that I've witnessed a lot and been thinking about is about how a lot of the reason why people can't access healthcare is because there's not enough infrastructure in third world countries for them to be even able to transport themselves to places that do have healthcare. So for example, there's a lot of countries where there's public healthcare that's available to urbanized areas, but people who live in remote areas simply cannot physically access them. So definitely a very complex problem. And I found that 43%
So
of
just to clarify, the problem statement is lack of transport for emergency care in globally to hospitals, right? And then you will end up seeing that different countries will have different access. Is lack of transport the specific question?
yeah, the way I framed it was more like lack of access to healthcare because of living in a remote area. And then if, yeah, transport or money is the problem, maybe that's like a secondary
Yeah,
question.
but what I'm trying to say is I think it's useful, this is just general feedback, that the problem statements should be very specific because it'll help you guide and narrow. And you can start with a broad statement, dig in data, and then make it more specific. So you
Yeah,
can
that's a
choose
good
both
point.
of them because, if you include all sets of circumstances and all countries and all places, it won't be a very crisp. Insights don't come so easily. So lesson
Yeah.
number one for projects, everybody, when we will choose projects to work on, we will focus on context. And so always choose a location in mind to do this analysis with first, and then you can broaden it later. So for example, if I don't know whether you chose a country or a region, sub-region.
Yeah, I looked at some world statistics and then I chose a specific region.
Okay.
So yeah, so thanks for the feedback. That is really useful. So about like 80% of the world population lives in third world countries, but within that, 43% of the world population lives in areas that are considered remote or rural. So that's like 3.44 billion people about. And of that population, 56% of those cannot access healthcare, likely because of this reason. So the estimated number of people affected by this is 1.9 billion people, I would say. And then I chose, like, I didn't look that in detail at like a specific area, but like I was looking at Latin America and the Caribbean, and specifically in El Salvador. This is the case of 60% of the whole population of El Salvador, which I think is about 1 million people. And the continent where this happens the most is in Africa, where 83% of people who live in rural areas cannot access healthcare. So yeah, I guess I looked at a couple different locations, but that's useful feedback.
Yeah, no, this is fantastic. Already when you start saying the numbers, you can see where transport can play a major role. And then I'm curious in terms of, there should also be a quantitative definition of what is a remote area. So how many
Yeah,
hours?
yeah, I was
What's
thinking
the
about that
current
too.
definition?
Yeah, I wasn't like, I didn't look very specifically at what they considered remote and not remote because I was also wondering how they got that statistic. But I think they considered it where they live like a certain number of hours away from like an urbanized area that has like public services.
Yeah, and I think if you all remember in the first lecture, I talked a little bit about this, that WHO has a kind of a policy that 2 hours from a health center for an emergency case is what the WHO gold standard would like to be. And then they evaluate, there's a beautiful paper on this, then they evaluate different regions around the world to show that majority of them don't meet that standard. So I think, and again, this just tells us that some of it has to do with density, that we need higher density health centers. Some of that also means that even the distance is long short, but the type of roads and type of access and type of transport is very bad. And so 2 hours is driven as that if there is an emergency as a human life, 2 hours is one of the windows to think about. And so I think rather than distance, one analysis is by the time.
Yeah, that's a good
Okay.
point.
And then have you posted this on Discord? Is there a
Yeah.
piece of paper where you scribble this out and it's posted?
Yeah,
Or
I
Google?
added like a little paragraph on Discord.
Okay. Yeah, I think one thing that's very valuable is try sharing these with each other, and some of you would have gone really in detail and others will learn from it, and the other way around. Some of you will pick up problems that are really sticky and difficult to analyze. And so I think this is why it's a sharing exercise. Okay, so we're going to do two more quickly. So maybe Suraj, and then I also saw another volunteer. Anybody who wants to, just raise your hand. We'll do Suraj, and then after that, so go ahead, Suraj.
Yeah, okay. Hi, everyone. So, I'm Suraj. I was thinking about light pollution very generally. I mean, it's very clear that, the skies are becoming like we can't see the stars anymore. But I used to think that it might be just a, spatially localized thing only in the cities and not in, if you go outskirts, it will be okay. But nowadays, if you drive also, like you in the long drives also, if you try to see stars from your car, you don't see it. So I was like, maybe it's a global thing. Like it's not just localized. So, and it turns out that now our Earth has a glow. Like there is a global background that Earth has and that is called a sky glow. So I thought like. What is the rate at which this glow is increasing and how our visibility is going to decrease. So yeah, so I was thinking that maybe it will be an easy problem because there might be obviously some satellite based data which can give us the answer to that. But I came to know that it is actually the answer is not very accurate because it has limitations, as in there is there are no satellites which measure at a global level where they have a sensitivity throughout the spectrum. So there was an experiment done for answering the same question in the Science magazine, and they used like 50,000 scientists across the globe, and they just gave maps of the sky with varying degree of brightness, and they just asked them to say like what does the sky look to the human eye as a sensor, and based on
So
that
Suraj,
they
just was there a number they convert to when we look as a human eye and I see
right.
something? Were they able to convert that into some kind of a score? Because from
Yeah,
between 0 to 10, if
yeah,
0 you see stars, 10 you see the
yes.
Milky Way, were they able to quantitatively put a number?
Yes, so I mean, what they did basically was they put so they have integer values for the clarity of this the map. They chose a particular map, and based on the decreasing clarity, they just have numbers 0, 1, 2, 3, 4,
Yeah.
5, and they use that numbers to just fit it to a linear or exponential equation. I didn't understand that in very detail, but it was
Mhm.
simply putting these numbers into an equation and extracting out certain parameters. Like one of those parameters was basically the rate at which things are declining, and I
Yeah.
just
And then
looked
have you
at
thought a little
that
bit
data,
about
like what was the
extending?
rate here.
What are the other numbers that you could think about? I mean, this is a study that they did, so you can build upon it. Any other
Right,
numbers you can imagine? Like, for
right.
example, one issue around light pollution is the source of the light to begin with. So if you were to correlate that with the satellite
Yes, yeah,
images looking at Earth inwards at the night time, there's beautiful data now.
right.
So are there other numbers that you thought about that are not in their study that you want to think about?
Yeah,
Like,
I mean,
what
like
is our light?
they
What
have
is the
mentioned,
sensitivity of our eye, for example? Uh,
right. Yeah, yeah. I was thinking about things like how the way we perceive the night sky, and maybe this characteristic, and we might you look at that spectrum and try to design filters which might suit or enhance our sensitivity to the stars with
yeah, but
respect to
before,
the
that's what
rest
I'm
of the
trying to
background.
say.
So,
Before you think about solutions, you have to put numbers. So what I would love for
right,
you to do is, for example, find the quantitative number for sensitivity of an eye to number of photons, for example.
Right.
Then write down or figure out, people have measured what is the average number of photon flux from a star. How does that change as a function of distance? Why is it that some stars are dim and some stars are bright? What does that look
Right.
like in terms of absolute numbers? Because before you think about enhancement, we need to know in absolute numbers, and all of these numbers must exist because so many people have been making telescopes and they make choices.
Sure.
So based on that, they must decide. Okay, so we'll take one more. I saw another person. So Rafia, I see your hand, but before you, I saw one more person that had raised his hand, but now has disappeared from my screen.
I think
So
it's Manan Gupta.
Manan, are you up for it? Or else the baton goes to Rafia.
Hello, sir.
Okay, Manan, are you? Yes. Were you excited about sharing what you've been thinking about on the by the numbers?
Right. Of course, but the thing is, my by the numbers is not biology related, if that's okay.
It doesn't matter. It's about any question, any idea has to be quantitative.
Right. So what I had about an idea was I wanted to figure out, so according to what I've read and what I've developed, I think industrialization is the key to reducing a country's poverty, at least in today's day and age. So I tried to research about why some countries such as India failed to industrialize in the past and even today struggle heavily to industrialize. But why some countries are able to industrialize much quicker, even though they are facing similar problems as other countries. For example, China faces the same problem as overpopulation and resource scarcity as India, especially in the time period of the 1950s and the 60s. So I tried to research what fuels growth, essentially, because with the fueling of industrial growth, even society as a whole improves, with diseases reaching an all-time low and your life expectancy increasing. So I researched about the levels of IQ that are developed by the growth of industry. And I saw that China's median age group of 13 to 18 had an IQ increase of 4 points every decade since the 1960s leading up to the 2010s, simply due to the fact that they were getting better nutrition and there was lower poverty rates in the increasing years due to industrialization. Similarly, India's IQ only increased by 0.76 points in the same time period over 5 decades. So that's a huge gap. And the only conclusion the paper come to was because of the lack of industrialization and wealth in the Indian economy. So with this help, I was trying to figure out what fuels growth and how growth could actually change society as a large. So I also saw that infant mortality in China reached an all-time high of 55% or so during its pre-industrialization or poverty period, as they call it, whereas it decreased significantly, reaching even levels below 10% after its significant economic growth. But in India, we do not see the case. So I tried to research about how industrialization fuels the growth of society and helps humanity as a whole.
Quick set of comments, Manan. And I think, you're all starting to go in the right direction. But I'm hoping that after the first round of thinking, you hone in on a specific question that will enable the sets of numbers that you calculate, then allow you to sort of refine and understand that question very well. So, if the question that you had stated earlier was why is it that rate of industrialization in different countries is different, then you want to make a list of every possible thing that you can measure, and then not the outcomes of industrialization. That's a separate question where you're trying to ask a question whether is industrialization has positive outcome in society. You can also choose that question, and then you can try to answer that with numbers that you can find. So I think most of the discussions that we've had so far are a little too broad. I'm hoping that you all work a little more on this assignment and try to narrow them down. And I'll go through the stuff that's posted on Discord, because one of the purposes of this exercise is to learn how to ask questions crisply. And it's fantastic to see the breadth of questions, but I'm still not hearing like crisp questions and numbers that then start to address them. And again, this is a hard exercise, and it is important to not just read somebody's paper and somebody's question and summarize it. That's not what we are doing here. It's good that you found a paper, for example, for light pollution, but you want to go beyond. It should be your question that you can use somebody else's paper and data to answer. So it's very important in
Apologies,
this
Professor.
assignment that you don't summarize somebody else's study, because they already did it. And the idea is to develop your chops around quantitative thinking. And so there is a distinction between it. And if it turns out that the exact same question you had in mind, somebody else has already done it, don't read it. Try to do it yourself. Because what I want us to be able to do is go beyond not just the numbers that you can find, but estimates that you could make that don't currently exist. So that's kind of the general set of a comment. One thing that would be useful is folks should read other people's posts. Try making these sets of posts on Discord, and we'll go back and revisit it. And the reason I'm spending so much time on this is one of the most powerful and literally a very frugal tool that you can use to understand your problem. Because if you can't convince yourself that you understand all aspects of the problem, you will be excited about what you are good at, which is good to be excited about, but sometimes solutions don't lie exactly in the area that you're good at. They lie in the nuances of understanding the problem itself. So that's all I want to say about by the numbers.
Apologies,
Rafia, I'll get
Professor.
back
I'll
to
try
you.
again.
I'll read your post on Discord, and I'll kind of do lots of feedback offline. And it's very valuable to make sure that you guys all have discussions on each other's posts. I want to spend some time on malaria, and I think we're going to run out of time because I only see we have maybe 40, 50 minutes now. So I want to switch topics. No need to apologize, Manan. This is not a yes or a no. It has to do with just, I want you guys to spend more time, sharper questions, sharper answers. And the whole purpose of this is if there's no feedback, then you won't know whether you hit the mark or not. So, as I said before, nobody's being judged here. We are all trying to do this in the sense of just trying to learn this process. Okay, so I think I'm going to switch topics. I know many of you got exposed a little bit to optics for the first time. I'm going to show you a demo of what, when optics is put together to a social use, what it can accomplish. And I'll do that in the very end. And this is also why I'm here, because in Senegal, we are running a clinical validation study for a new malaria diagnostic. Now that diagnostic is sitting to my right, where I am in the clinic right now, and I'll show it to you in the end. But we're going to jump a little bit and talk about just malaria briefly. And again, this is interactive. Some of you do actually live in areas. Actually, show of hands, how many of you currently live in an area where you know that there is malaria transmission? I mean, the place that I'm sitting definitely has malaria transmission. So Peter, give me 1 second. I have to go offline for just 2 seconds because here is Mukhtar, who's one of my collaborators at Institute Pasteur, working on malaria for many, many years. And I think at certain point of time, I'll have him join the class because some of his students will also be in the class. But give me 1 second. I have to figure out the logistics, whether I can stay in this room or not. So I'll be offline for 2 seconds. Don't go any.
Hey, Magna, did you have a question that maybe I could answer?
Hey, Hope. I was just raising the hand for a minute for the malaria question that Manu asked.
Okay, got it.
Okay, yeah.
We can just wait for him to figure out the room.
Okay, sorry, I can stay in the room. I have to just train some of the students and they're trying to figure out when I'll be free. Okay, so I think I want to talk about malaria and very much in the, so I saw Peter's hand. Peter, I'm curious, can you tell us where you are connecting from and just the local context of if you have had the chance or your chance encounters with malaria?
Well,
Peter, can you hear us?
yes.
Yes.
Can you hear me now? Of course. Yeah.
Yes, we can hear
Sorry,
you.
my bandwidth is a bit low. I'll try and
No,
show
audio is
video.
perfect.
Okay, so I'm logging in from Nairobi, Kenya, and we have a serious malaria problem because the western part of our country and also the coastal region has high malaria burdens. And then, of course, because we have a huge rate of rural-urban migration. So we have quite a number of cases also we see in Nairobi, in the capital, because of transport. And then an emerging problem is global warming. So we now have what is called island malaria. So there are areas where there never used to be much malaria, but because of the warming temperatures, we are now beginning to see malaria. And of course, as you know, the problem is that when the mosquito expands its range and starts causing malaria in a new population, you start seeing a lot more cerebral malaria and also death from malaria because there is no immunity at all. Yes.
And then, Peter, which region did you say? What was the
So we
closest
have
city to where you
we're
are?
in Nairobi. So we're in Nairobi. So I'm in Nairobi,
Yeah.
Kenya, which is the capital.
Yeah.
But I'm saying where we have a really, really serious malaria problem is the part of Western Kenya, what is called the Lake Region, Kisumu, Homa Bay, Siaya counties there. Then in the coastal region, that have a severe malaria problem. But now, as I'm saying, the highland areas neighboring Kisumu and also Nairobi, we are beginning to see an upsurge in malaria because of global warming. So.
Yeah, and I think one thing that Peter just highlighted, which maybe in the very end I'll talk a little bit about, is this very dangerous path that we are on, that people who have no immunity being exposed to malaria. So the places that have new cases because of the changing climate and changing mosquito, that really makes this problem really complex. And, of course, I'm sure all of you have heard about malaria. And in today's discussion, we're going to try to talk a lot more about what is new. You might say, oh, I've heard about malaria and I know everything about it. And I think just Peter's words should reassure you that this problem is an ever-expanding problem, not an ever-shrinking problem. And it has new facets that we are absolutely not ready for to begin with. Okay, so I see Meghna's hand. Meghna, I'm curious if you have had an encounter with malaria. Also, if anybody has had a personal encounter with malaria and they're willing to share, I would love to hear that. I'm happy to share mine, but go ahead, Meghna.
Hi, I'm currently calling from India. In the WHO Southeast Asia region, India accounts for the highest number of malaria. I'm saying all these data because I'm pretty much tuned in with it. I'm a doctor by profession, so and I'm interested in public health, so I am up to date with the data. I've seen the clinical side too, how the clinical picture is and what the complications are. And I have an experience in Ethiopia. And
Mhm.
I mean, the malaria experience in Ethiopia is much bigger than what I see in my state in India. I mean,
Mhm.
the African region, there are almost 240, 250 million cases of malaria annually in the world. And out of this,
Mhm.
more than 95%, almost 95% is from the African region. And
Mhm. Yeah, and then Meghna, I'm very curious because I will talk about kind of the broader statistics, but you as a clinician, uh, any stories that you want to share? What do you see? How often,
yeah,
when say a young kid shows up at your door and you think you have symptoms, what happens? And if you can also give us a context of, is this your clinical experiences in a hospital setting? So I
yeah,
should think about it's a big hospital, a district hospital, which level?
yeah. I
Because
did my,
we would love
yeah,
to sort of have everybody in the class feel that they are in your shoes.
yeah.
And what
I
happens when
mean,
you're
yeah.
actually providing clinical care in a malaria region?
Yeah, I can share the experience from a tertiary care hospital. What we see is people come in with fever and I mean high fevers. It's not just a normal fever, high fever, most of the time cyclical. And we as clinicians, we have, I mean, since we are an endemic region, malaria is one of the top diagnoses. Among the differential diagnosis, malaria is, one among the, it tops the list. So we do the malaria test, at least a rapid diagnostic test, and then once if we are able to start that treatment in the right time, the clinical picture is totally different. I mean, it's treatable. It doesn't go into complications. But the thing is, it has to be diagnosed at an earlier stage. I mean, especially if it's a variety of malaria called Plasmodium falciparum. I mean, it's notorious and it is known for causing cerebral malaria. And luckily, the falciparum cases in India is much lesser. It's more of an African and Caribbean, threat. Not much of a big issue in India. But if you happen to get a falciparum infection, the clinical picture is totally different. You know, it's not that easy to manage, and it has to be diagnosed at a very early stage, which often doesn't happen. Because most of the time when this in clinical picture, it's just fever. People, especially, people from a poorer setting, they tend to, keep things aside. They tend to delay seeking care, and they most of the time present late. And if they present late, the purpose of treatment and the clinical course, the thing that happens because of the late initiation of treatment, it's unimaginable. People deteriorate at a very fast rate, and they can go. They die. Let me be direct, and they die because it's not that easy to manage beyond the point. Early diagnosis and the awareness among people to seek care when they see symptoms. Those things are key in malaria treatment and in prevention too. Yeah.
Yeah, so I think, one of the things that's very valuable is, and we'll talk a lot more about the details of the sets of numbers, but hearing from the clinician and you sharing some of your top priorities is actually very valuable. And so, I think just as a lab for the last 10 years, we've been working on malaria and specifically malaria diagnostics and mosquito surveillance. And now there is a tool that we have that we are very excited about, which is rapid identification of malaria in the field, but with as sensitive a tool as possible. So this is a little bit, we will dive into some of the complications of why you should all still care about malaria. I think if it wasn't obvious already, Meghna talked about just the mortality itself is just absolutely devastating for communities. But then also just new ways of thinking about interventions in malaria because of the challenges that we are facing is an ever-changing landscape itself. But I think this is also why this class is so much fun, that every time I'm thinking about a topic, there is somebody who's actually experienced it on the ground. We've been working in Africa mostly and now in a region in Kalahandi, and I was trying to figure out and dig in some of the pictures to show you all from the clinic. I'll show you a little bit of the vision from the clinic. And the context is very different. And, just the sets of problems, the kinds of solutions that you also need. So understanding this local context also becomes very important when you are trying to think about a specific problem. So let me share my screen. And what we're going to try to do is just do a very rapid. So as you all know, we could spend, I would say, a whole year just talking about malaria. And I'm just going to spend the next 40 minutes. So this is almost a tip of the iceberg. But the reason I wanted to bring this up is just for the folks that are interested, you can all dive in and engage in this problem. There's a whole bunch of projects that I have in mind that if there are teams or two, I think the reason I'm choosing some of these case studies a little early on is because of my desire of some of the teams to actually engage. So, I think the first place to begin is really the human picture. This is a site that I often see in clinics that I visit most often. So most of the places that we have worked in the past has been Nigeria in the region of Lagos, Cameroon, now Senegal, which I'll talk quite a lot about Senegal in a little bit, Uganda, Tanzania, Madagascar, and also two regions in India, Kalahandi and in the Northeast. And then a little bit of kind of some feedback from partners in Indonesia. And so, this is a very classic case that you see in primary health centers. And so I think my viewpoint of what we have done and we've been thinking about and our knowledge base really comes from primary health centers, which becomes extremely difficult again to handle the clinical care side of that story because there is very little to begin with. On average, whenever I'm out in a clinic, I see roughly per day 100 to 150 patients. That's actually a good number to think about in terms of people are showing up. Most of the time, it's kids with fever, because as Peter pointed out, as you get exposed to malaria, some of the adults develop immunity also, but kids are at highest risk to begin with. But again, it's not as if that there are no symptoms for kids too. And just my own personal story around malaria is with this family. This is a picture from Uganda. This picture haunts me a lot. And one of the things that I think about often enough is, this is obvious to many of you if you look at this picture carefully, that these are graves of young kids. And most often you would see this driving around in Uganda. Every little household you stop by, you see huts around, and then you see a few graves right in the middle. And kind of the conversation, you can see the mother is pregnant, and then the conversation led to this thread around not wanting to forget. And the reason I picked up to talk about this, and also just I don't want you to forget, because often enough, diseases like malaria and TB, although they get attention, we have kind of gotten used to them. And so unlike COVID, when something came about, we really thought of them in a perspective of engaging very deeply. Everybody had a reaction to it. Sometimes things like TB and malaria, even many governments become complacent because it's just either it feels hopeless or it feels like, oh yeah, we've heard about this and we're doing the best we can. And I think I'm here to argue that we're really not doing the best as we can. So, I think in terms of thinking about just numbers and something that might come as a surprise to some of you, and some of you might have already heard this, every year, the number of malaria cases that are being reported is actually rising. And that's a pretty striking statistics to think about because it's a disease. It's really the oldest infectious disease to think about. The fact that with all the resources of the world, with everything that we are trying to put in, so the last World Malaria Report, the 249 million cases is the 2022 number, and the 244 million is the 2021 number. And this is not a COVID. Of course, COVID was quite a worry because we really dismantled some of the capacity and some of the capacity was shifted. So people were very worried about what this number will look like. But even without a COVID context, and I'll show you this as a trajectory, that the last, I would say, 50 or 60 years, there has been a tremendous drop of cases. And I would argue that what happened there was the low-hanging fruit gains were taken, and much of the low-hanging fruit comes from, say, starting the use of bed nets. And then again, if you don't think about cases and you might think, oh, people have immunity and it's okay to be positive, it's still, we are really talking about 600,000 deaths. And a significant portion of them, which we'll kind of consider, are really kids under 5. So that number can be as high as 80% for most of the places. And so you end up in this situation that a very vulnerable population is essentially being exposed. The regions that I'm in the Sahel region right now. Tomorrow I'm heading out to border town in Gambia, and then you essentially start seeing a massive increase. As you go further down south from Sahel, Dakar is okay. There's very few cases here. It's too dry. But the moment you go beyond the Sahel belt, you suddenly see a very large peak. And then, of course, Peter talked about a region all across, and I think I should probably have this somewhere here. So this just gives you the geographic interplay of the problem. And you can see the areas where it's lighting up. This is a 2017 plot. So I think ironically, there is a lot of data and statistics. I didn't pull out the new one. You can see in all the way in Peru. I don't know if anybody recognizes anybody connecting from Latin America. What region is that where you see lighting up? Does anybody know? I don't know if we have anybody from Peru connecting, because I know lots of
Here.
students were there from Peru. Oh, do you recognize the region where you
Yes.
have high, huh?
Yeah, that's Loreto. It's
Yeah.
called Loreto.
So,
Yeah.
yeah. And one of the things about this is also in the Amazon. So another class of challenges in delivering healthcare. And of course, Africa really is one of the biggest burdens to begin with. And we'll talk a little bit about it. And again, the pockets of India and the Kalahandi region that I was talking about is in that region of Orissa. And I would argue a little bit about that these maps, although very useful, I don't think they truly tell the picture because many of them are not updated. And many of them, even for malaria, the WHO report that comes out actually comes out a year late from the data that's collected and transferred. There is really no real-time dashboard that we have for this problem, which again is a massive issue to be thinking about. So now when you think, this is some of slightly older data of what people have been seeing in terms of thinking about the change of cases. This is really the 10 highest burden countries in Africa. And, around 2013 or something, we started seeing something different where there has been this upward trend of rising. And ironically, this doesn't match the investment. So when you think about just financially speaking, you could argue that there is a lot more that we can do, which is true. But financially speaking, the world's, donations and the amount of money that is invested in malaria has been capped around 3 billion. Now, that's a very small number compared to world economics and when you really think about, but that's really what it is. That majority of the investment has stalled. Some of that goes to very standard places like bed nets and other sets of things, RDT supply, some of the drug supply, and it's not as if we have more resources to expand while the disease is expanding in ways that we are only just starting to understand. And I think another way of looking at this, which is, and again, malaria, if you type in, you can find every statistics that's possible. I like this because it also tells us that when you make SDG goals, we often sometimes think about that, oh, we have an SDG goal, and by just creating a goalpost doesn't make a problem, the problem doesn't go away. So that's the green line is where we are supposed to be. And the blue line is where we actually are. And even in that predicted state of the best possible thing, 2030 goals, there are lots of countries that have elimination goals. India actually has an elimination goal. Does anybody remember what the India elimination goal is? I know there's lots of people connecting from India. And so I'm curious if any of you know, because when a country commits, then we have to dedicate time, energy, and resources. Does anybody know what the India predictions or what is in the policy statements? My intuition was somewhere around 2030 itself, but I am trying to remember. I might be wrong, but 2030 is not that far, actually. It's only 6 years away. Yeah, Vaibhav, go ahead.
Professor, I looked it up just now. Actually, it's
Yeah.
to reduce the malaria deaths by 90% by 2030.
2030, 90%. Okay.
Yeah.
And I think one of the important things around this politically is it used to be that no country would want to use the word E word. It's called the eliminate word. And only now we are starting to get bold to be thinking about, could we ever even eliminate malaria? And there's lots of countries where there is positive news and people are starting to actually think about eliminations. This is on the death side itself. So same sets of issues around cases and deaths. We just are not making the dent that we actually need to make. So this is all I want to say about kind of the disease burden. And I think one of the things about this is, I see a hand. Pawan, go ahead.
So I'm just trying to understand, because I always had this imagination that if we just put enough mosquito nets and drain the swamps and drain the tires, we solve the problem. It's a very naive view. So what you're telling me right now is, have we reached the logical end of it? Or is it that because the funding has plateaued, we don't have enough resources? Or what are we missing that we can't hit it? Like, where have we stopped? Like, is this not sufficient? Or am I being too
No, that's a $1 million question. First of all, this idea that if we are going to just drain the swamps, mosquito breeding would stop is a fiction. If you visit any of the places with high burdens, this is what every puddle looks like. Even a tiny, cap of a Coke bottle is enough for a mosquito to breed. Even a tiny hole inside a wood is sufficient for a mosquito to breed. And again, although there is lots of effort that have been put, I'll talk a little bit about, there's a massive series of things. And, in summary, it boils down to resistance to insecticides to begin with, resistance to the drugs themselves, our diagnostics not being sensitive to catch any of the low carrier population. So there is always a carrier population present that don't show any symptoms even. So they will never actually show up to the doctor to begin with. You end up having both resistance to the diagnostics itself. So there are strains that we have selected accidentally that are now resistant to the current diagnostic platform, which is a really strange thing. That why would you choose? I'll talk a little bit in detail on this, but you end up investing in a technology that then itself, it's not an essential gene, so the parasite evades it, and you end up implementing something and making the situation worse. So similarly, there is the notion of new regions and completely new vectors. There's a beautiful study out of Kenya where they showed that the use of bed nets essentially traded a behavior change in the mosquito, and the mosquitoes and the sets of species that are slightly earlier biters when you have dinner essentially took over the burden. So by any perturbation you make in a biological system, it responds. And I think not having real-time capacity and feedback loops in this process, you cannot operate blind. And I think that's kind of one of the key messages, is what we learned from COVID in the management side of that story is a lot of our threads were real-time. And it's a very complex biological loop. And, just as the context of thinking about just what is really going on, malaria has a stage that lives in a mosquito. It's obligatory to mosquitoes. It passes through your bloodstream. Then it infects several sets of organs. Then it matures. And the maturation cycle that's going through is when you get periodic fevers. So every 24 hours, for example, every 48 hours, when the parasites multiply, they double in numbers. And that's when you get the fever, because literally a significant portion of your red blood cells are then completely kaput. And then, of course, a mosquito picks up the blood and then it transmits it to the next person. So, the biological aspect of this is complex. And again, many sets of tools we have developed have been around the vector side of the story. Many of them have been around treating patients, several sets of diagnostics. And I think what's very exciting on the horizon is vaccines. And we will just briefly talk about it. But that's really one of the big major portions of the meeting that we are here today, are also just discussing do we have enough momentum in this problem to bring truly vaccines to the table? And, I think to a certain extent, some aspects you could say that the technology is getting there, but there is nothing that's truly efficacious that could actually be deployed at scale. So, to answer your question, it's a fairly complex landscape. I'm going to give you a little bit of insight into the diagnostic space, because that's what we focus quite a lot on. And then people should interrupt, because I would much rather make this a discussion, because I want to spend time just sharing some of the open problems in the hope that some of the teams might get inspired and then choose related themes around malaria as a problem. So, I think I had mentioned diagnostics. So let's just take a look at what the diagnostic landscape looks like. There is 3 sets of approaches to it. On the very left is a PCR test for malaria, something that will be sensitive to either one parasite per microliter, or even less than one parasite per microliter. RDTs that we will talk quite a lot about is the most abundant diagnostic that's accessible and available. There is of the order of around 300 million RDTs are used just in Africa alone annually. And one of the things that's valuable is that PMI and many sets of organizations, a significant PMI is President's Malaria Initiative. Significant portion of their funds actually go in the RDT and RDT access. All the RDTs are subsidized, and that also causes market problems. As you can see, that picture of the RDT I chose is made by Abbott. And I don't know if some of you know this, that when COVID sprung up and the demand for the COVID test was so high, there was a panic in the malaria community, because Abbott was essentially using the same lines to make COVID test as they make the malaria test. And the panic was that if they stop manufacturing, there are no manufacturers locally, which is a huge problem to think about. If 90 to 95% of all tests are used in Africa, but there is actually no local manufacturers that meet that set of standards and quality. I think India definitely is starting to grow and manufacture more and more of malaria diagnostics, but it's not there yet. And then the last bit is microscopy, which is what we work on. And what's actually fun is I am literally right next to my samples. So these are patient samples. You will see, I have a microscope right here, so I will actually be able to show you some parasites. So just to give you a context, that's the traditional workhorse out in the field. It's not in this good shape and quality, which we will also talk about, which is a huge issue in microscopy. And then I am assuming you have all been bitten by mosquitoes. Is there anybody who has never been bitten by a mosquito? I'm just curious. Nobody's raising their hands. I just got bitten while I was giving the talk 30 seconds ago. It's starting to swell, but I was able to actually catch it. So I'll show you guys the thing that just bit me. I don't know if you guys can see. And then, of course, one of the big problems is I'm showing this to you, And could you identify the species? It's a huge problem because now I don't know, and I'll show you some of the tools we've been building in that space, whether this is a malaria-carrying mosquito or not. A very important problem associated with the vector side of the story. And then, of course, I'll talk about the tool in a second that we've been building on the malaria diagnostics. So, I think one challenge when you think about diagnostics is I need to just show you what the reality of field sites are. I think Meghna mentioned a little bit about tertiary hospitals. As a lab, we primarily focus on primary health centers. So I'm going to give you a walkthrough of a primary health center in India, in Kalahandi. And I'll just let this video play for a second. Right now I'm outside. It's a region right outside. And then it's a one-room hospital. I already walked through the entire clinical area. And I have this time lapse running for 8 hours. We're not going to watch this for 8 hours, but I just want to show you these are 2 lab technicians continuously nonstop for the next 10 hours. They will be doing diagnostics. And what I love about this is some of you can see this tiny window where my mouse is. This is where people knock on your shoulders and tell me, hey, can you tell me my result? So now that's Durga and Prem, and he has a red notebook. That's really the patient record. And he has now started imaging. You can see he's looking. And then on one hand, he has a cell counter and he's touching to count the number of cells. It's actually important in microscopy to be able to tell the level of parasitemia. And especially for severe malaria, there's a cutoff number that you should not release. And especially for kids, you should not release the patient. You should give the drug, let the parasitemia go down. So quantitative detection is very important as well in clinical management, because then you don't know whether are you actually treating it or not. Now, Prem would spend roughly around, on a day that's very quiet, he would like to spend around 20 minutes or half an hour to look at a negative slide to really confirm that it's negative, because he wants to hit that low parasitemia count. But now, as I said, 100, 150 patients show up. So in a day, in 24 hours, you don't even have enough hours to actually be able to do this. One of the other aspects of this is oil microscopy, and the stain and the process that's being used is called a GIMSA stain. And just so that you all know that although we claim and think about so much innovation everywhere, the WHO standard is a GIMSA stain, but GIMSA stain was actually invented in 1904 by Juan G. GIMSA. So we're actually using literally the exact same tool that was invented to discover the parasites themselves. And it's quite remarkable in terms of thinking about sometimes in certain sets of places and sets of ideas, very little changes. So this is one paper that I like. I think going back in the numbers, it kind of analyzed for different sets of countries, what are the statistics. So the ideal performance that we want to have for a diagnostics is 99% sensitivity and specificity at 10 parasites per microliter. If we can do that, we really have a chance of catching a ton of cases that are the reservoir. And currently, what we are achieving is less than 40% and sometimes between 40 to 80% sensitivity and specificity at 1,000 parasites per microliter. So 2 orders of magnitude larger load, and we are still hitting this 40% number. And you can see when this number looks so low, you might as well toss a coin and you might have a better chance. And I think this is one of the challenges that effectively the sets of approaches, both RDT and the microscopy, don't hit the mark for what we would like. While at that same time, there are places that are doing well, and also you still need much and more sensitive assays to be able to detect malaria. So this is where the current standard, and then I'll take your question in a second, Pawan. I just want to say one more point, which I find quite interesting, which is literally the capacity for microscopy. This has to do with sometimes, when RDTs came about, most countries decided to dissolve their capacity and training around microscopy. So India is the only country that has caught on with training. I can't say there's no good papers about quality because there's no quality control built in. But 50% of all malaria slides are read in India, although it has less than 0.31% burden from a mortality perspective. So it's very interesting that certain sets of countries end up deciding to support. And one of the things that ends up happening in this situation is the challenge around the RDT ranges from two reasons. One is that there is a gene called HRP23 gene, which is what we are detecting in the RDT. And what happened was when this gene was selected, somehow we ended up deciding that we will choose a non-essential gene because it was expressed in abundance, so you could make a sensitive RDT. And now the parasite has decided to basically evade it. So we have selected a strain that we cannot see. And so, of course, the numbers that we are talking about, and I find baffling. We implemented 300 million per year RDTs, and we choose a gene that is not actually essential. And, I think the history of this is really fun. If somebody wants to really dig in and read how these sets of decisions get made, and then now people are scrambling to find other genes, but they're not sensitive because they're not expressed in abundance. So there is a threat to think about computationally and by other means. Is there a way to pick up? And again, RDTs take many, many years to develop. This is not a trivial task when you change a new gene sets. I have one friend who started a company and they're looking for new targets right now, and it's very difficult. And then the other aspect of this in the diagnostic perspective is the spread of the drug-resistant strain. And this has to do with many of our treatments. The first line, the best treatment, the artemisinin-based sets of treatments are now seeing drug resistance around the globe. And so you end up in this situation that, most places, the reality is if you have fever and you live in a malaria endemic zone, you go to a pharmacist and you say, hey, I have malaria, give me the drug. What that does is it compounds the problem because then more and more people are consuming these drugs and either not completing the dosage or they don't even have malaria. And that leads to a lot of drug resistance to begin with. And so many of these things boil down to a point that you need to rapidly be able to diagnose. And then how rapid is rapid? For falciparum, which is the abundant strain, within 24 hours, if you're not diagnosed, you could actually be in a critical condition. And 5 days, you will pass out. You're done. So if you have a child, you see a malaria symptom and you did not, the first day you're like, oh, let me see, maybe this is some flu or something else. You've missed the chance to actually catch it. And that becomes extremely dangerous because the mortality for falciparum is just really, really severe. Okay, Pawan, go ahead.
Yeah, I don't know how to respond after listening to all of this. It's just unreal. I'm sorry. It now
No, I
comes
think
up.
that's how I feel every day. I think this is kind of what I find sometimes that
Yeah.
there's so many things that we can do as a society, but I don't think we have done enough in terms of thinking about much of the most of these class of diseases. Yeah, go ahead.
Now the techno magic naive solution, like what's the rate limiting step with respect to the microscopy? Is it the slide preparation? Is it the human skill? Or is it actually staring at the slide and figuring out, and that's the labor intensive step? Like what's the time consuming step in this process?
Yeah, all the above. And I'll actually show you what we have been building. One really is just the fact that a human, when they are looking at a slide, is only looking at between 3,000 to 5,000 cells in 20 minutes. That's a very small number of cells. The number of fields of view, the more fields of view you see. The other problem is just the strain. If you are working for 10 hours and at some point of time you get tired, and I will put a slide on the microscope with my phone. I do want to show you guys what parasites look like. The other aspect of this is associated with the fact that training is a huge issue. So I will let you guys identify parasites in a minute and see if you can find certain class of parasites. So all of these things get compounded. And again, this is really, we know a lot more about this because this is exactly what we've been working on. And I'll show you a solution today that we are now starting to deploy. The tool is called Octopi, and then I can post this on Discord as the paper if people want to read. Actually, it might be that it's time. Maybe I should just do a demo because I see a question from Tushar and Mrinal. Why don't you guys ask questions and then let me do a demo first? Because if we run out of time, I don't want to leave you guys hanging with only negative news. So let me share something positive as well, because I see lots of sad faces, and there's a lot that can be done. And this is a platform that I'm very excited about, many of you engaging. But I'll take questions, and then Pawan, I'll show you what we have built. So Mrinal and then Tushar.
No, I don't have a question. I just want to add something that what Manu said.
Yeah.
Like you said, RDTs have essentially resulted in selecting the strains of parasites that are giving false negatives and false positives. But something that I understood was something that was made to help mankind became an issue. I was with Magna working in Ethiopia, and something that I saw was people, since RDTs have a huge false positive and false negative rates, the people there, especially in low income and low resource poor settings, they stopped going to the hospitals, to the primary health centers and the health posts. So that's what's happening right now, and that's one of the reasons why we got in touch with Manu too.
Yeah, and I think that this is also an issue around trust. And this is also where malaria, the social context of this, the trust in the medical system, and many a times there are other alternative things, solutions that people start looking for. So it is a compounded, and I think many places with malaria also have other conflict zones and other things that then make it very difficult to be able to build a reliable health system. So I think one important thing to understand in the context of malaria is clearly technology has been lacking and we need to do a lot more, but there is a social wrapper around this. Okay, a quick question from Tushar, and then I want to show you guys something that I'm excited about. Yeah.
Right. So, Professor, you're talking about how in some instances, let's say that a child gets shows those symptoms, and the parents could be like, okay, it might be just flu and stuff. So when you are dealing with this issue of malaria, how do you deal with this issue of people not realizing the severity of the problem upon identifying the symptoms, like, because it gives rise to a whole different domain of problem, right? Like education, outreach and stuff.
Absolutely. Yeah. And I think, again, if some of you are excited about malaria and take this on as a problem, I mean, when we will train many of you on Foldscope, one of the common things that we do in the field and programs that we build is show people very directly the parasites, show people the transmission process, show people this, I think there is a lot of evidence, but there is a lot more of interactive activities around building trust in the healthcare system. Especially, I mean, some of the education programs that we've been thinking about are really around teaching germ theory. I'm just reading some messages from Hope. I don't know. Yeah, I think some people are asking about the other RDTs. They're incredibly expensive. And I think that's been one of the challenges, that currently the common RDT is what's implementable, and all the other ones, because they haven't hit the mark, the market hasn't switched around. They don't have the kind of volumes. So some of those expensive can be as expensive as $10 per test, which wouldn't make any sense in terms of thinking about 300 million tests that need to be done. But there's a lot of people thinking about sensitive RDTs. I think it's a difficult task, but the hope is that it'll work. I'm going to show you a slightly different solution. And I don't know, Hope, if you can, or maybe I can do this, I'll pin my video because I want you all to see the full screen. So at this point, do you all see me on the full screen, right? Because, so this is what we've been working on. Can you give me a thumbs up? Can you actually see this on full screen? No.
So people on Zoom,
Okay.
or I can pin you, Manu.
Yeah, if you just on your end can pin that way, because I'm just going to show it directly rather than show you a video. It's really fun to do live demos. So this is the first live demo. One of the things that you will read about in that tool, and then I'll mention why I'm emphasizing this tool, because it's a platform for doing imaging-based diagnostics. So one of the places that we started with was this idea that if we can have self-driving cars, why can't we really have completely autonomous microscopes that do everything in an autonomous manner? So from that idea, 10 years later, we now have the world's first completely autonomous real-time malaria detection machine. And, I want to emphasize the 10-year part because it does take that long. But the hope is that now once you can establish something, that a lot more things can be built on top of it. So the instrument is called Octopi. It actually has a slide already inside it that I'll show you. There is an optical arm here. There is a stage. There's a couple of electronics. It all gets boxed into a single box that I'll show you. But because we're setting this up in research facilities, I like to undo the box. But eventually what you're about to see is a live diagnostic demo. And on the screen is essentially the object that we're interested in. And I don't know if you can all see, these are blood cells, right? Do you all see the cells right there on my screen? That's from a
Yes.
finger prick, single drop, smeared on a slide, and I'll tell you a little bit about the smear. But now this image is live because if I move my objective, you can see the things are moving. And now what I'm going to do, and this is sort of the magic part of the story, is I am just going to start the machine to run the test. And you see this new screen has shown up. The instrument is collecting phase contrast, bright field, and fluorescence data. It's moving to new places, but now in real time, it's actually identifying individual parasites. And now if you all look right here, on the screen, it's while I finish this sentence, it's looked at and read 46,000 red blood cells and identified 96 parasites, and it's done. So now, while I finish those two sentences, it's picked up and identified, and every one of them is actually a ring stage. And so what's very, only because you all have been playing video games as a society, we got GPUs, and now we could accelerate this. And so now currently the entire thing runs in real time. And one of the things about this is, say, for example, the quantitative nature. Amongst the 55,000 RBCs it read, it has 96 positives. It only looked at 18 fields of view. But if I wanted to, and if the symptoms, or it was an asymptomatic case, I could have actually gone in and tried to increase the number of fields of view. And so you can read, within 5 minutes, you can read roughly around 20 million cells with this instrument. And so that gives you the comparison between what the human can do roughly around with, say, 10,000 cells to 20 million cells. And this is this needle in a haystack problem. And one thing that's also fun is you can actually see some of the tough cases where, in this case, this was on the edge. There's a number here, which is the probability associated with this. And in one of the lab sessions, we will have many of you both drive the instrument, but also I'll talk about this in the context of machine learning, train the instrument. Right now, we have trained it for falciparum ring stage, but there are many stages associated with different types of species. And we can also train the instrument on different types of models. And one of the reasons now, kind of the direction that we are going with this, and let me just show you all this one more image associated with this. So, I think I just showed you where we are today, but this is quite literally many years of journey. So the hardware that you saw used to look like that in 2016. That was a 3D printed system. It kept evolving, and now it's become essentially a box right there. So this is what the current system looks like. And one of the key approaches of why I'm so excited about microscopy is we started asking what else can we do with the same tool. So with another partner, so of course, this was almost 7 years of work of a PhD student in my lab, Hong Chuan. And now Hong Chuan and I are trying to commercialize and actually manufacture these to get them out to people. But one of the fun things has been is that the entire hardware and software stack is open. So we have lots of now partners that are starting to build new diagnostics on top of this platform. So this happens to be Pranav, who was in Nepal. This was a study done in Nepal. He took the same box and then implemented sickle cell anemia detection on it. Similarly, there is another TB assay that we've been working on. And there's another assay that we are working related to sexually transmitted diseases. And so one of the fun vision that I'm excited about, and this is kind of what I want to end the class today, is there is a possibility that with a framework like this, we could literally create an app store for diagnostics. Same hardware, the slide is roughly between 1 to 5 cents. And there are hundreds of diseases that can actually be detected using imaging. And the thing that I'm excited about, and any of the groups, if you end up choosing diagnostics and imaging-based diagnostics, we're starting to ship this hardware to teams that have some of the clinical and machine learning expertise for a specific disease. So for example, right now, in Tunisia, we're starting a project on Chagas. And the goal is to have locally people that are engaged, and if there is a high burden, to have ownership of that. The regulatory framework would look like that the hardware gets approved for a specific sets of apps that are already there. But then as over time, more and more AI-based diagnostics can be built on a standardized platform. So now what it does is it just lowers the barrier for many more people to actually enter. And then from a Ministry of Health perspective, they will make an investment, and then suddenly 6 months from now, instead of 10 diseases, they could potentially have 20 or 30 diseases in the same clinic. And so microscopy has this very special place where it's a platform that's applicable to a very broad range of diseases. So this is kind of the reason that I am in Senegal. We are starting a clinical, there's a couple of validation studies that we have done, but now we are starting a very large scale clinical study to see how long and how robust the instruments are, whether they will actually survive in primary health centers. As I showed you that picture of a primary health center, there is intermittent power. So these instruments operate on basically cell phone batteries for 8 hours. The cost of what we can build this in just bill of materials is roughly around $3,000 to $5,000. And so that's kind of what took this long to be able to do, because if you do this for $100,000, that's the entire yearly budget of a primary health center and more. So that doesn't make any sense. So it really is about building a kind of a cost framework around these sets of tools. And I see Khan has a question. Go ahead, Khan.
Yes, so thank you for your great. Basically, I'm pathologist by myself, and I look at
Perfect.
microbe every day. So I'm
Yes.
very
And Khan,
excited
where
about
are
this
you based
system.
right now?
I'm now in
Where
the
are you
Dana.
based?
I'm now in Boston, Dana Farber, but actually came from Vietnam. So we
I
also have
see.
a lot of
Did you
malaria.
say Vietnam? No.
Yeah, Vietnam.
Vietnam. Okay.
Yeah.
Yeah.
So I think like we can apply this system to a lot of things, like cytology in that cancer diagnosis or something else. So I myself, maybe every day I look at it maybe more than 200 slides it's very tired to check like the cytology every cell and everything. And I also
Yeah.
saw in your paper about the tissue scanning. Tissue scanning now we have a lot of slides. So before I go maybe more than 10,000 case per year I diagnose it. So a lot of that slide, and then we have a lot of very
And I'm
big data.
assuming the tissue slides are cancer.
Everything
or-
like both cancer and not cancer.
Mhm,
So,
mhm.
but it's a scan machine very expensive, so we cannot have now. But this is a very great. So, like if we can scan for diagnosis real time, and we have a large database for machine learning, everything. Yeah, it's very
Yeah.
great.
And I think one of the reasons this is just a fantastic, this is also why, again, I'll repeat it, why this class is so much fun to teach, because many of you bring completely new capabilities to the table. This is the reason why I'm excited about this new model. So we are starting to basically make and ship the research version of Octopi to lots of people that are excited, and then having them take ownership of building and developing another layer on top of it. Because we need to exponentially increase what these sets of tools can do. And that only happens when the people who have the best clinical insights and have local data set are the ones that are added, because you need the highest quality data and you need really good training to trusting. And this is also why, going back on trust, we do this, when I do this with primary health centers and the community health workers, when they see the parasites in real time, they know how to identify them. So then there's a trust that builds in the AI, which is very critical. Like, I think there's a lot of work that's happened in which the trust is lost, and then you don't know whether, what you actually did mattered or not. Yuki, you had a question.
Yes, I have. I just wanted to ask in terms of what are the data sets that you currently have for the images of different, diseases? Because I think, and also if there's someone who can easily sort of identify the ground truth or like categorize them, because I think.
Yeah, so I think we
building
are
it-
just starting to build and also release the data sets. We have around 1,000 patient data set on malaria from Uganda and Tanzania, and now the plan is to do another 2,000 from Senegal across the belt in Sahel. And these numbers sound too small to me when I think about, hold on, we have 200 million cases. I would like our data sets should be in millions. We're not there yet. We only have a few. We have 10 machines now that are distributed with partners. We're trying to go that. I did a calculation that if we had 100 machines, in a year, we could very easily build 1 million patient database, digital database for malaria. That's something that I'm excited about, looking for funding in terms of trying to figure out. Then we have data sets on TB. That's another big data set. This is a cohort in South Africa. Chagas is the one that we are just starting on. And then in Kenya, we're starting to do sexually transmitted diseases and bacterial vaginosis in vaginal smears. So that's kind of another space. And one of the things that is helpful in terms of thinking about is identifying sets of places where they have both clinical access, they have patient access, and also the interest and desire to be part of the solution itself. And so what I would love to do is basically find around 20, 25 partners. We have a whole list of things that we have identified that these tools should be trained for. And the idea is to have cohorts take on a specific disease and literally run a Kaggle type app competition. And then again, two groups can work on the same disease. One group's model will be better, and then just whatever wins, just like they do in computer science. It's, competition is good in that sense. And whosoever's model best performs on the hardware is the one that should actually go towards regulatory approval. So the reason I spent a little bit time on this is because I'm excited if any of you end up choosing, we have also built kind of zero code machine learning tools that allows people who have clinical insight to then build a ML model and then validate those ML models. So in terms of projects, one thing that I am excited about is at least having one team that will be microscopy based. where you end up choosing a specific solution on top of it. So yeah, I think Khan, that would be just phenomenal. Like, of course, I didn't even know this. So already it would be very straightforward. And I think this is also why, when I think about a lot of diagnostics, the clinical aspect of it is very important. Like, what is the sensitivity, specificity that will matter to a patient? It's not just about what we can actually do. What does it matter to a patient? And that teaches us how quickly we should deploy tools. So this is a very important thread to think about. I'm wondering, was there a question, Hope, on your end? Or I'm looking at the time, so I'm going to end pretty
Yes,
quickly.
there is a question in class.
Okay, there's a question in class. Yeah, I'm sorry, I don't see the hands. You guys are like so far away, but yeah, go ahead.
Can you hear me?
Yes.
Yeah, I guess I was just curious about what the main like motivation behind like developing like microscopy tools over just like qPCR, other molecular diagnostics. I know you talked about like the gene target was like being evaded, but I feel like for a lot of like other like TB and stuff, like there's a lot of qPCR and I don't know if it's just cost or like just developing like cheaper
I
thermal
think there are a couple of things, and one of the things to think about is with so many diseases, so many context, so many financial sets of resources, the approach to take on diagnostics is let all flowers bloom. This is just a general approach in science. It's very important for all of these sets of technologies to rise to the table, but then eventually it's the cost that drives adoption. So for malaria, we have been targeting a 1 to 5 cent test, that at a local place, it should cost less than 5 cents. RDTs are a couple of dollars. A molecular test can be, all the way from a few dollars to even tens of dollars. So for example, one of the things that happens with RDTs are subsidized, but molecular tests are not subsidized. So in a hospital setting, when you have, there are machines, for example, that do completely automated in 40 minutes, they can start hitting the 1 parasite per microliter. But what's really needed is a very high sensitivity test at the 10 parasite per microliter, but which the cost is almost free. And so one of the things that is important in thinking about microscopy will never beat molecular diagnostics directly in just its performance. But when it comes to cost and the amount of infrastructure that you need to run a molecular test, that's really where the axis is. And then again, there are certain sets of things that are better to do with imaging. There are certain sets of other pathogens that are much better. They are so rare, and you might actually be very interested in a molecular phenotype. Like actually, when you think about TB, you reminded me of drug-resistant TB. There's very specific gene markers that you could look for that then suddenly have a clinical impact. And so I think these questions are tough. It's not one thing wins the race. It really is about making sure what is the clinical goal. An ideal case scenario, the business models around molecular testing have not risen to the challenge as far. I don't think it's a technical problem. And then in a later part, because we also work on that, I will spend a lot of time talking about molecular diagnostics, and you will see kind of the approaches that we've been thinking about and approaches that are now live. It's just what has happened is over the years, microscopy capacity has degraded, while in general, the computational imaging and the power to be able to do small amount of robotics has expanded so massively that machine learning now has a very interesting role to play in this space. So it's also about taking advantage of that, what exists on the platform, to rethink what you might want to build. And I think I'll kind of do the microscopy, or actually somebody could choose that as your by the numbers project if you want. Do a comparison between diseases where a molecular test versus a microscopy test might actually be the right approach, and do it for a specific country, for a specific context.
Cool, thank you.
Okay, yeah, go ahead. I'm already over 10 minutes. I don't want to hold you all too long. Specifically, most of you end up waking up this late. we did the poll trying to shift the class half an hour, and the class was split half and half. So I don't know, we could still convince, I am still open of moving the class up by half an hour. If you guys are getting used to working late night, then we will just continue this way. But I think it is valuable. I think I cannot emphasize how valuable it is that many of you take your time and connect so many times a week, because without these conversations, none of the local context would actually matter. So, I think this is just an absolute joy. And I know it's an awkward set of a time, but this is how we will end up building teams, because you will all get to know each other much more in person. And that's really what drives much of the trust in the new project. So at this point, I'll officially close so that the folks that have to run can run, but I'm still here. Pawan, I'll take your question, and then we can have just a slightly general chat. And then I couldn't get the time to show you guys pictures from the field in Senegal. So maybe I'll just share a folder of what the clinical sites here look like. And then Meghna and Mrinal, if you guys have a small folder of your time in Ethiopia, and you might want to just make a small folder and just share. I think it's just really valuable for people to walk in our shoes sometimes. It'll be fun for people to see, okay, what did it feel like to do clinical duty in Ethiopia? Okay, we'll take your question, Pawan.
So now this looks just phenomenal. This is the techno magic of saying, could we go ahead? And probably is like the XKCD joke of, like, can you tell if the photo was taken in a national park? And the computer scientist says, yes, very easy. Now, can you tell if it's a photo of a bird? And it says, I need a research team and 5 years of time. So, and I think we have reached there with respect to large language models and they coming in with vision. So, and it's only going to get easier and better with the hardware. So now, where does this lie on the plot you had shown earlier of the sensitivity specificity in the ideal range, where you had shown earlier in
we hit 95% for the 10 parasite per microliter. So we hit that mark. I mean, and this is also why we've been just developing. Even what's published in the 2019 paper is actually much, much older than this system. So I think this is also why the trend of improvement in these types of systems is actually incredible. And again, the speed is a big criteria for us, because we really want under 5 minutes a diagnosis. And currently it's even faster than that. The other aspect of imaging-based approaches is that you could tune your models, that if you are operating and working in an area with very low parasitemia, you could build a model that's really trying to find a needle in a haystack in very large number of cells. While if you're working in a very abundant area, you can, because your goals are slightly different. So this is also why it's valuable to be thinking about the amount of adaptability in instruments like these. And, I think the other part of this is also just trust and easing the burden on a community health worker, because there's only one lab tech. I mean, the video that I showed you is from one of these NGOs in Kalahandi, and it's rare to have 2 lab techs, and even their hands are full. So just imagine if you were just all alone and you were doing not just malaria, but everything under the sun. So this is also another aspect of the lab life, is how do you ease the effort, like the amount of fatigue that a person goes through makes a huge impact on a clinical side, and especially the outcome. The numbers are low because people have a very, they're just exhausted. Okay, I think it's 7:20 on my end. I am gonna let you all go. We will continue, and I think again, I will post the newer version of the Octopi so you can all see and walk through the software stack. And then one of the things that we will pick up is we will do a session very dedicated to machine learning this year. And in that, I will go under the hood to talk about what you just saw, how is that possible? And then think a little bit about what does it take to do training for new class of models. And I think, again, because machine learning tools are so scalable, they fit in the bill of frugal science if we can get them to actually tackle appropriate problems and not just letting people click on advertisements and make movies, which is also good, but they should go beyond entertainment. Khan, go ahead.
Yes, so I'm so very excited about it. So definitely I will join this project. But I got like it's possible
You
like
also
you.
send me, can you send
Yes.
me a note on
Okay.
Discord so I can read a little bit about your samples, but I think I can already
Yes.
commit. This would be straightforward to get you one of the
So
units.
and you consider to deploy system in Vietnam or something else? I can
Yeah.
join in it.
So
Yeah, because we,
I visited Vietnam. If you have sets of partners, right now I'm struggling to find a site
oh, this
that
is
has
surely
Wi-Fi.
no. Okay, so my hospital before we have a 3,000 patients per day.
Mm-hmm.
Three,
And
three. So every day, like we have a lot of specimen and maybe more than 100 by cytology and histopathology. So my patient now 3,000 beds. So it means in terms of data,
no, I think
what
Vietnam is not
clinical
on the
and
map as I was initially comparing Vietnam and Cambodia.
yeah,
And I think what would be very valuable is if you have a partner hospital or a partner individual or a group in mind,
yeah,
that would be pretty
surely,
straightforward. And I
yeah,
think
yeah,
the
yeah.
thread would
Okay.
be is for you to also, if you go to Vietnam that often, that would also actually be valuable. And again, I think this is true for all kinds of projects. As you're all
Yes.
thinking about final projects, they should be context dependent. So think not just about, like, for example, Yuki's project is based in Congo. So it has to work in that context. And so similarly, Khan, as you're thinking about, think about the context and the location. The location is incredibly important to choose. You don't have to be at that location because we can always find a team member that might be at that location. But any solution only matters in the context of a specific place. So it's very valuable.
Yes. Team member, I can do that because I work there for many years. In my boss and my colleagues and in my students there. So I can connect definitely. They can send the slide for me every day to actualize diagnosis. So that is great. Yeah.
Yeah. Pawan, that's a great comic. I'll use it in my talks. Yeah. All right. I'm going to say bye. Unless there was any other burning question, we'll catch up. I think I will be back by Monday, so I'll see you all in class. And then on Friday, yes, a quick thread. On Friday, we will be doing a rundown for CAD. Some of you who have never done CAD will be doing the design. While some of you who have some experience, we're actually going to give you the CAD of Octopi and give you a CAD of another tool, and you will modify and see if you can try building a box to make this, say, sandproof, waterproof, or I'll pose a few sets of projects around CAD, but make sure that you all download Fusion 360. And I think we'll just basically run, it'll be a working session. So you just need a computer. And then we'll catch up. I'll post what we will be doing on Friday. Bye, everyone.